I like to give the example of a very good friend of mine who's a psychiatrist in Nampula province in Mozambique, who's the only psychiatrist for 6 million people. Jennifer Mootz, assistant professor at Columbia University in the Department of Psychiatry. Many low and middle income countries, especially in sub-Saharan Africa, there, as a result of colonization, there has been a lot of conflict since that time. A lot of turnover and instability in political governments. And because of that, people have been displaced, forced to relocate to other countries, and exposed to many different kinds of traumatic stressors. Many times, substances are used to cope with depressive symptoms or anxious symptoms of trauma, and manifest in that way as more of like a secondary problem. The underlying problem is really depression, anxiety, trauma, and other mental health issues, and substances are used to then cope. A lot of my work is in sub-Saharan Africa, and we had been talking amongst ourselves in the global mental health field about where are the men? And a lot of people gave anecdotal evidence about having interventions that they were providing, and mostly women were attending those interventions. So we just saw it as a huge gap and opportunity, and we're looking for experts who could fill some of that gap in global mental health. Speak about communities in Africa, I just want to say that it's a very diverse place. So it's hard to speak for many different kinds of communities, but mostly I work with rural communities, those who've experienced some kind of armed conflict or are in low resource settings. I think about the natural institutions that are there and community organizations that are already in these spaces. So many people will offer some kind of mental health services through religious organizations, for example, and things that people already access because there are very few professional or specialized services in mental health. I like to give the example of a very good friend of mine who's a psychiatrist in Nampula province in Mozambique, who's the only psychiatrist for 6 million people, to give an example of how scarce human resources are. And we really need to think about how to change our services from a traditional hospital-based kind of service that we think of and often deliver in Western contexts to be much more flexible and community-based. What we think about more often are similarities between low-resource contexts globally. So it might look a certain way in sub-Saharan Africa, but we're also bringing this task-shifted model, which means that we train people who don't have formal training in mental health to deliver mental health interventions. This could be primary care providers or community mental wellness workers. And we're bringing this model to New York City, which people think of as a very high-income sort of setting, but it's very diverse. Cluster has helped me feel emboldened in many ways because there's a lot of support and interest. There's a lot of expertise that I draw from, so I can present some of our findings from Mozambique, get feedback from the cluster, and I already see it benefiting.